Thank you, Lou, and to all of our speakers. I'm going to stand so I can see hands. We're going to go into a short Q&A session. So let's get the ball rolling. Yes, ma'am.
So that was done by our regional MCH coordinators who would actually go out. So for those that would not link to a birth or fetal death, those regional coordinators would go out, abstract medical records, abstract everything they could find to try to find out, like, for instance, if it was a miscarriage or, or if there wasn't a pregnancy. There was no evidence of pregnancy. So either way, they would go out there, they would try to get that information from abstract.
Yes.
Hi, I see that there's this congressional caucus on maternity care. Beyond that, what are the top action items that should be passed along to our process?
It's a great question. I mean, I think funding for the National Center for Health Statistics, they help pass along funding to the states on a regular basis. And I don't think they've seen, we've at least been level funded, but we haven't seen an increase in five years at least. And as we start relying on these national electronic systems to provide all of our partners with almost real-time data, right, for surveillance purposes, for the public health purposes. Better, faster data means better, bigger, faster electronic systems, and they are not cheap. They aren't, and it's a huge lift for individual states. Most of them end up raising the money and paying for them in-house. They are usually not paid for by the feds or any other partner. And that's a pretty huge burden to place on, a very small part of what's normally, a public health office in a state jurisdiction. So I think funding is number one, absolutely. And drawing attention to the real data, I think, is also a really valuable ask. It's very easy to, especially in our news cycle right now, to grab onto what's said and just take it as the word. But as you've heard, like some of these maternal mortality news stories are, not accurate at all. And so the question becomes, we need to be relying on and using the right data. And the right data is the vital records data, right? Because it comes from the source. Yes?
Just real quickly, I'm Anna from Jamie Brewer Butler's office, and I'll just add to that, HR 1318 was on one of the slides.
Yep.
We'd love to have all of
More support.
Join the bill. Debbie's also here from Congressman from Butler's office, and our boss's co-chair of the Maternity Care Caucus. So again, just a shout out to that. We'd love to have you join, and we're here to chat about what we need to. Thank you.
Thank you. Yeah, Jonathan, you had your hand up.
Yeah, first, thank you. It was a very fascinating presentation. I had two questions for Dr. Lewis. So one, the facts and figures sheet that you alluded to, is that complete for the states? If not, how many of them are available is the first question. The second one, for the interventions that you identified, was there any follow-up done to determine if those interventions have been operationalized and if those percentages were still consistent or improved or dropped anywhere?
Okay, so is this on? I'll answer the second question first. That yes, as part of those initiatives, we would go in and do site visits. We had them report certain metrics, and so none of the sites ever operationalized 100% of everything, but they all did better. And you know, we also gave out awards to top sites who operationalized most things. The best example that we have of it working is the state of California. California is a leader in this. They implemented these initiatives a long time ago, and they substantially reduced their maternal mortality rates. In fact, they rank #1 in the country for having the lowest maternal mortality rate. And you figure that's a large state with a lot of high-risk pregnancies, but yet they were able to do it in part using these tools of reviewing every single maternal death and then implementing these initiatives. So we think it does work, and there are other states that are also leaders in this. New York has made a lot of progress. North Carolina, Illinois actually came after us, and they learned from us. But a lot of states are doing these things now. But again, you need the data. To answer your first question about whether these fact sheets are up live, not yet. The person responsible is right behind you in the white jacket. Hi, Katie Shooter.
Very, very soon, and we will be sharing all of this information with our partners and our members as well to sort of explain exactly what people are looking at. So very, very soon.
Thank you. I had that exact same question, Jonathan, so thank you for asking it. Yes, ma'am.
Hi. So first of all, I broke down statistics. I didn't get quite all of it, but you mentioned that the crime index had gone from 14 to 43% for the space. That was in how many days?
10 days.
10 days. Okay.
So the event is reported within 10 days.
Okay, great. And then what are some measures you think that states can do in order to improve crime rates?
That's a great question. So one of the things we've focused on in the past couple of years that has made a huge difference in those numbers is the implementation of electronic death reporting systems. Again, those big, giant, expensive electronic systems. They really move the dial in terms of not only timeliness, but quality. We've still got a handful of states who do not have an electronic death registration system. In some cases, it's not about money. It's about state IT system, when they're upgrading their system, they just can't do it yet, political will. There's a number of reasons, and they're not always financial. If it were just financial, we'd definitely just throw money at it and have it be done. But it gets complicated. So having electronic death and birth registration systems, they're two separate systems that each jurisdiction has or should have. And being able to upgrade those systems, we've spent the last, I don't know, almost 10 years now implementing EDRS and EBRS in all of the states. And it's at the point now where our IT folks are saying, I don't know, that code is really old. I'm not sure I want that on my system anymore. And so we're, again, like we're at the point now where we're having to rebuild them, do the enhancement, do the big upgrade. And states really need help with that. They really need help with that lift.
And are there any, I guess, special costs, or not costs, but like ways to help states with really high maternal mortality rates? I feel like maybe that could help if they were able to report faster.
Yeah, I'm going to throw that one to the panel. They are our state experts. What could help most at the state level to improve maternal mortality rates?
I think each state is going to be different as far as what's really at the foundation of those rising rates and the high rates. So each state's going to be a little bit different, and it could be anything from legislation to funding for a certain initiative to target something that's going to actually affect that change. So I mean, I would say like it's almost like a specific to the state and the reason, the underlying reasons why that rate is so high.
Right, and having the resources to roll out this pilot to more than 4 states would be a great start, right? I mean, it's a great partnership with DRH, and if we could do it in every state tomorrow, we'd do it right away, because obviously, you know, it points to the problems immediately. Dr. Lewis.
Not to sound like I have a one-track mind, but again, back to the data collection, right? So, you know, the bill that supports that, making it easier for each state to collect their own data, because I 100% agree that it differs by state. We were surprised to find in Florida that it was still hemorrhage and hypertension. In California, the top cause of maternal mortality is heart disease. So again, the interventions are going to be different depending on what's the top cause. You know, in some places it's opioids. So you need to get back to the data. So I think supporting that piece of legislation that will help make it easier for states to get their own data. And then the next piece is supporting these perinatal quality collaboratives, because they're actually using the data to then go in and make changes. We were lucky in that the CDC put a lot of money into this, but that was the then director who decided to do that. With the next director, that may not happen, and so I think funding those initiatives will help.
Lou, did either of you want to?
I think can you hear me?
Yeah.
Okay. I think one of the things that would help, the physician community needs to pay attention to how the care is being provided and the importance of the documentation of the procedures, but also reporting to us in the death certificates and assuring that they're completing things properly. It'd be really good if CMS and CDC and others could work together well to convey that. We all know that funding and money talks to providers. And, we think there's some mechanisms that could be considered, or at least I better say I think there are, but some opportunities that could help physicians realize the importance of what they do, how they document, how they complete death certificates, how they complete any of the documentation to assure that these are properly documented and reported. That would go a long way. And then paying attention to how they take care of the moms, I think is just huge. It's just really unfortunate that we're at this point.
Yep.
Can I just add to that?
Absolutely.
Again, starts with the data. You have to have the data to know what are the causes of the maternal mortality, and then, you know, that access to care, you know, the availability of that care, working with the physicians, the doctors, the nurses, the midwives. That's one piece of it. But having that data to identify what are the barriers to a woman accessing that care that might be beyond the medical system. You know, I've seen some figures that say 60% of maternal deaths are preventable. You know, a large proportion of them happening after the woman leaves the hospital. And so what systems of care are in place, and how do we support those women, you know, are all really important, but it has to start with the data so that we know where they're happening, what are the causes, and then we can really start to look at what are the barriers to accessing that care.
And I would just add, not that I think this is rampant and, you know, within our system, but we've all, at our level, Devin and the DC team and others, we've had those issues where a doctor might tell us, you know, our vital records team will call up and say, cardiac arrest is not good enough to tell us how this person died. Well, we get pushback. It's not my job, or I don't get paid to do this. That really shouldn't happen. And I don't know, like I said, if they could get 50 cents to fill out a death record, maybe that would pay, you know, raise their opinion. I don't know. It's just very frustrating. But those are the things that we battle all the time. And I have an administrative assistants that are calling up physicians and saying, you didn't put enough information on here, and you can imagine how well or how not so well that's happening and getting more information. So there's some paradigm shifts that have to happen in the value of what's being reported on these records.
Can I add to that too? You know, one of the things that DC has done in the previous medical examiner is actually to have CEU credits for how to complete a properly a death certificate.
Yeah, and our vital records agencies do a lot of outreach. Their field staff, most of the jurisdictions have staff that are dedicated to go out and educate people on a rotating, everyday, ongoing basis, just going around to every hospital, every funeral home, building that relationship, making sure they understand the importance and respect the data. But that job really shouldn't just fall to vital records alone. That's the job of medical examiners and coroners and physicians to make sure that data is correct. And I'm not sure it's just a different perspective, right? But it's one that really challenges us daily on the quality of the data side. Yes?
Hi, so just kind of building on that, what are the efforts to improve maybe medical education and capturing these students before, while they're in medical school, to kind of, be more thoughtful about how important these statistics are to the data and to improving outcomes in the future, as opposed to, I think the work that you're doing now is important in terms of having these rotating groups kind of going in and providing education, but can we capture those or start increasing awareness earlier on and infusing it into the curriculum?
Yeah, this is something that when we get together as vital records professionals, we talk about all the time. It's on our wish list. It's high on our wish list. And I think just getting the attention of the physicians' organizations is a challenge for us. There are lots of things going on in their world, and vital records seems like a very low on the priority for them. So I think there are current educations, especially in the residency programs for physicians, especially if they're doing maternal child, obstetrics, gynecology, but it's certainly not something that is pervasive across all physicians, and physicians are about preserving life and not about death, so it's a tricky thing to be teaching them. But I'll pass it on because I'm sure you guys have some experience.
Yeah, in our training program, we start at the resident level that they do fill out death certificates, that they're the first line, and we oversee it as sort of a way of, introducing early on the elements that are part of adult life, even just as a trainee. But for sure, it's not persistent, and not all institutions do that, and that's where I think sort of there has to be some advocacy for that on a higher level with the organizations that govern the components of residency training.
Yeah. Yeah, we have toolkits, and we make them available to all of our member jurisdictions, and their field staff use them and give them to the physicians, especially the local physicians associations in their states, but it doesn't guarantee that they get used. Lou, did either of you want to add anything?
I just want to, we're having difficulty getting into those medical institutions. I know there's a lot on their plate, but every now and then I'll get in on a luncheon, please, and they're very anxious. They're like, hey, can we just tell you, like, if somebody's in hospice? Well, yeah, but okay. Please just do all the other stuff. So there's not an interest by the physicians. It's getting through in the medical institutions because they have so many things they want to teach them. And I think the other unfortunate thing in trying to get these broader statistical pieces of information and the need for them through, we're so compartmentalized in how we train our physicians. I'm interested in dealing with a particular organ system, and that's all they talk about, that's all they work through. So getting just that higher level public responsibility is kind of fallen by the wayside, I think, unfortunately, in some areas.
Anything else?
My name is Ms. I don't know what Sean said about systems and costs. For us, if you're advocating for funding, so for us in the district, we need funding to get those systems to maintain them, because we live off what we earn, what we generate from those records. So if we don't have money, we we can't build those systems. And so I just want to put that out there as a takeaway for us. Maybe other jurisdictions may not have that, but for us, that electronic systems. And then we're talking about in the future interfacing with EHRs and all of
Right.
that. So that's going to be another pot of money or another bucket of money that I know that a lot of jurisdictions may not have money to do.
Right.
So that's just one thing out there. And then, you know, in terms of the general approach, this is wonderful and it's getting out there because we do, by legislation, have a maternal mortality review committee by statute. And we had a kickoff but that's under our Office of Chief Medical Examiner, and that's not fully functioning the way it should be. So we just had a hearing about maternal mortality. So what came to the table that we're trying to have them broaden is to approach this from a perinatal health rather than a maternal mortality. And then the definition seems to be interchangeable. Maternal health versus pregnancy related, because what was presented here by definition is pregnancy related. So when people are not on the same, in terms of using the same definition,
Right.
we're reporting maternal mortality to be everything but within 42 days. And then you're using, and other people here are using maternal mortality to include everything up to a year. So I think we need to be careful about how we use the definition, because then when what's reported, people are not reading what's in the line under that box.
Right.
They're looking at the numbers, the title, and then they're saying, oh my gosh, we have this crisis here, and I'm not saying that, you know, to Devin's point, that reporting is 100%
Accurate.
the way we were. We needed to be. But I just want to put that out there, because a lot of times I have to explain when the media calls or other people call why is such and such reporting the numbers that way, but you're reporting this way. And I'm saying, I'm going by definition of CPC, WHO, this is what they say, this is what they say. So I just want to put that out there.
That's a challenge shared by many jurisdictions. Having a media call in and say, we've seen this number, and then having our vital records agency having to kind of back up and explain statistics 101, you know, which they don't want to hear, right? So it's important to be comparing apples to apples, and explaining that is always a challenge.
If I could address just a little bit about the funding. I know all of you probably had to get your birth certificate, particularly to get your real ID, your driver's license, et cetera. We get our funding through the sales of these pieces of paper for you to be able to go and do your business. We're trying to evolve away. Eventually those pieces of paper will go away, but that's what we live off of. We sell those. We're not being very successful at being able to recoup the cost of selling our data or getting our data, sharing our data, however we deal with it, through electronic processes. We really don't get the return on investment. So what's really unfair that a lot of us have concluded is that widow or widower that has to come in, they need 15 copies of a death certificate for their loved one to settle estates, that we have to raise their individual price for a record to meet the cost to provide this data to do our business. And that's unfair. So we are working hard to try to find ways to recoup some of our costs through the sharing of our data through electronic methods now. I mean, I think there are ways to share that burden across the myriad number of researchers, users, federal agencies, et cetera. So our future is going to be looking toward finding ways to recoup those costs. So you may be hearing more about that at some point, but I just don't think it's very fair for people needing these records to have to foot the bill for other groups that are using the data and get funded. That you can't tell me there's not a line for data in a grant application. It doesn't make its way back to the Vital Records Office. Very rarely do we see that funding. So it's been a mixed bag for us to be able to continue to operate and be able to invest in our systems.
Well, I'm being given the high sign. So thank you very, very much for coming today. Please contact us with more questions. Be happy to talk to you. Thanks again.